Hello everyone, my name is Dr. Rutuja. I am second year PG resident in Department of Radiodiagnosis, Dr. V.MISAL Government Medical College, Nanda. My topic of presentation is neonatal adrenal hemorrhage, diagnosis and insight. Aim of this study is to analyze the risk factor and clinical presentations and ultrasonographic findings of adrenal hemorrhage in newborn babies. My primary objective is to identify and differentiate adrenal hemorrhage with the help of ultrasonography from other benign and malignant adrenal lesions. My secondary objective is to analyze the risk factor and clinical presentations leading to adrenal hemorrhage. Neonatal adrenal hemorrhage occurs during the first week of life. Its incidence is 1.723 per thousand live births. In the newborn, adrenal gland is vulnerable to hemorrhage due to two reasons. First is a unique vascular supply. 50 to 60 arterial branches originating from the three suprarenal arteries supplying the adrenal gland is leading to the enhancement in vascularity. Also, the 10 to 20 times larger size of the adrenal gland in comparison to the adult body weight. Etiology can be multifactorial, but it most commonly occurs after traumatic delivery or neonatal course complicated by hypoxia, hypotension, or coagulopathy. It most frequently occurs on the right side due to its location between liver and spine, leading to its compression and drainage of right adrenal vein into the IVC, leading to the venous pressure alteration. Regression can be between 2 weeks to 6 months. Etiology and risk factors for neonatal adrenal hemorrhage can be traumatic delivery, difficult extraction, prolonged labor. There can be history of asphyxia during the delivery, large for gestation as babies, prematurity, shock or sepsis, coagulopathy can be a risk factor. Sometimes incidental finding will be there. Also, the presentation for neonatal adrenal hemorrhage is asymptomatic in most of the cases. Prolonged jaundice, anemia, hypovolemic shock, abdominal mass can be a presenting feature. Also, scrotal discoloration and adrenal insufficiency is found in the rare cases. Ultrasound is the best modality to diagnose the neonatal adrenal hemorrhage rather than CT because of few results. First is a non-invasive nature of ultrasound, cost effectiveness, bedside availability, and dynamic visualization of adrenal gland. Also, non-existence of the ionizing radiation, and with the help of color Doppler in ultrasonography, we can differentiate accurately from the hemorrhage from other benign and malignant lesions. So the ultrasound is best. This study is a descriptive observational study. I have done this from the November 2023 to November 2024. In this study, I have included newborn with jaundice, abdominal distension, birth trauma, perinatal asphyxia, or newborn with any risk factor is included. I have recorded primary hospitalization region, gestational age, gender, delivery type, birth weight of the baby, presenting symptom, predisposing causes, sign of adrenal insufficiency, site of neonatal adrenal hemorrhage, and ultrasound findings were recorded. Repeat sonography was done after the 2 weeks for a follow-up scan. Total 11 patients were included in this study. Ultrasonography plays a critical role in diagnosis and management of neonatal adrenal hemorrhage. On ultrasound, hemorrhage typically appears as a hypoechoic or unechoic area, depending on the age of hemorrhage. In case of older hemorrhage, it shows mixed echogenicity due to the clot resolution. Ability of the ultrasound to access both size and location of hemorrhage is crucial for monitoring its progression and determining the need for further intervention. In addition to identifying the hemorrhage, ultrasonography can be helpful to guide the decision where follow-up scan such as follow-up imaging such as a CT or MRI is necessary or not. So overall, ultrasonography is an indispensable tool in early detection, monitoring, management of neonatal adrenal hemorrhage. We can avoid the radiation exposure which is present in the CT with the ultrasonography. Also, the time-consuming modalities such as MRI can be avoided, and ultrasonography will be the best in case of non-ability of the further imaging in the lower level neonatal centers. Out of 11 cases, I have included some cases in this presentation. First case is a 2-day-old male preterm infant presented for general ultrasound examination. Patient was asymptomatic, but there was a history of asphyxia at birth. On ultrasound, right adrenal gland was enlarged and normal size left adrenal gland is noted. In the right adrenal gland, there was 2.5 by 1.5 centimeter size oval mixed echogenicity area is noted without any internal vascularity. In second case, this was the 3-day-old male term neonate with a palpable abdominal mass in the right hypochondria in the lumbar region. The risk factor for this case was a birth weight of the baby, which was the 4.1 kg with a history of gestational diabetes in mother. In this case, 3.2 by 2.6 centimeter size hypoechoic area is noted in the right adrenal gland, with 3.1 by 2.1 centimeter size mixed echogenicity area is noted in the subhepatic region. So the diagnosis was made as a right adrenal hemorrhage with a subhepatic collection. In this third case, this was the 6-day-old female term neonate presented with the anemia. In this case, 5.4 by 3.2 centimeter size hypoechoic area was noted in the left adrenal gland, which is showing mass effect on the underlying left kidney without any internal vascularity. And follow-up scan was done after the 2 weeks, showing the reduction in size of the hemorrhage. In the fourth case, this was the 5-day-old preterm male neonate presenting with a pathological jaundice. There was history of eclampsia during the delivery, and on ultrasound, 2.5 by 1.8 centimeter size hypoechoic area noted with the central hyperechoic area might representing the clot. This lesion was not showing any vascularity on a Doppler study. In this fifth case, this was the 3-day-old male term neonate, came for general screening. Their birth weight of the baby was 2.3 kg. On ultrasound, there was a 2 by 1.1 centimeter size hypoechoic area in the right adrenal gland with a normal size of left adrenal gland. Result of this study was out of 11 neonates, 8 were term neonate, and there was a male predominance. That is 7 neonates were male. Right adrenal gland was most commonly involved due to its location. Also, the majority 6 neonates were with a birth weight of 3 to 4 kgs. On ultrasound, there was a adrenal mass which was showing hypoechoic echogenicity without any internal vascularity, and it was showing mass effect on the underlying kidney. There was no case with a calcification in adrenal gland. After conservative treatment for 2 to 6 weeks, complete resolution was found up on follow-up scan. This pie chart, we can see that 46% cases, that is most of cases were asymptomatic in this study. Jaundice were found in the 27% cases. 9% cases were palpable abdominal mass. 18% neonates were present with the anemia. There was no case with the adrenal insufficiency. And there were 64% male predominance was seen. Also, 48% babies were with a birth weight of the less than 3 kg, but greater than 4 kg, that is the higher birth weight of the babies was also seen as a predisposing factor. Right adrenal hemorrhage was found in 82% cases, left in 18% cases. There was no case with a bilateral adrenal hemorrhage in my study. Conclusion was, right adrenal gland was most common site of hemorrhage due to its location. Also, the mostly adrenal hemorrhage can be asymptomatic, but identifying a risk factor and early evaluation with ultrasound will be helpful. Adrenal hemorrhage in neonate rarely lead to the development of adrenal insufficiency, as there was no case with such presentation. Ultrasound is a best modality to diagnose the neonatal adrenal hemorrhage. With the help of color Doppler, we can differentiate adrenal hemorrhage with the other malignant lesions. In conclusion, neonatal adrenal hemorrhage can be detected early by sonography, and most cases require only supportive treatment. Thus, unnecessary surgery and severe complications due to delayed diagnosis can be avoided with ultrasonography as a modality. These are some references. Thank you.